Hi, welcome to T4. We're so glad you're here for this talk today. I'm Dr. Alanna Bree. I am a board-certified pediatric dermatologist, a speaker and advisor for CeraVe, and my favorite job, the director of pediatric dermatology collaboration for Sagis and the host of T4. That's why we're here today. And today we're going to be going on the mission field to Nicaragua and also Guatemala. So buckle up because this one's going to be a fun ride. It's going to be lessons that I've learned on the mission field in Nicaragua and Guatemala, and then also just a few cases that stood out while I was on the mission field. One of them being segmental pigmentation disorders, and then also allergic contact dermatitis. So buckle up and let's get going. When you go on the mission field, you really have to change your perspective. And it's a little bit different. It's nice to get away on the mission field. Not only does I think it regenerate and rejuvenate you in a lot of ways, but it really helps you capture why you went into medicine. Dr. Dana Diven, she was actually the president of the Texas Derm Society. She's a dermatologist in Austin, and she coordinated this trip through her church, Austin Christian Fellowship, and we supported Nicaragua Resource Network. And this is still an opportunity that's available. I know Dr. Diven would be happy to talk to you about it, just as I would be. And we were able to go to Managua in Nicaragua, and we evaluated 1,000 patients in 1 week. And we worked together in orphanages, we worked together in schools, and we had the good fortune of really getting to interact with these kiddos who loved having us there and showing us their skin because they don't always have that opportunity. And then we worked together in churches. And as well, we were able to deliver food to the community. We visited the hospital. This was really interesting. We went to a maternal infant hospital and we got to see their hydrotherapy unit, which was really shocking in some ways and made me just feel so fortunate about what we have here in the US. We were able to see the patients. And again, we are such a resource-rich nation. And when you step on the mission field, you just realize how lucky that we truly are. We had a great team of dermatologists. We had pediatric dermatologists, nurse practitioners, Mohs surgeons, residents in training, and it was just such a great group to work with. And as far as the diagnoses, so the patients, common things are common, and that is no different when we were on the mission field. So pityriasis alba, that was a big one. And so many children were worried about their pityriasis alba. And we were able to dispel some myths because a lot of people believe in those areas that it is a sign of a nutritional deficiency. And we know that you can get dyspigmentation with certain nutritional deficiencies, but we were able to reassure these children and also their parents that this was just kind of a low-grade eczema. It's more common in darker skin or just more obvious, and certainly UV exposure or sunlight makes it more obvious. So again, just being able to reassure was great medicine, and it didn't cost anything. Certainly eczema, just as it's common and increasing in the United States, it was very common there. We saw a lot of just generalized kind of atopic dermatitis, and when you're on the mission field, a lot of these conditions, because they don't have access to the medications, are fairly progressed. So just really being able to go over good skincare with them and just reminding them to put on moisturizers. They do use Vaseline quite a bit in Latin America. So just, you know, and then just the mild soaps. A lot of people use very fragrant soaps, so trying to get them to use less fragrant soaps. And again, simple education can make all the difference. And then, of course, like in most resource-poor areas, infections and infestations are very common. We saw a lot of tinea corporis, certainly a lot of tinea capitis, and then the big one, scabies. There was a lot of scabies as well. So common things, again, being common not just in the US, but also on the mission field. No matter where people are in the world, they worry about their skin. And that is universal. So what is also universal is people appreciate you listening to their concerns. And we know, again, that when you sit down with a patient, it's better to sit down, to focus on them, to look straight at them, and that will help build your therapeutic alliance with them. we also know that people like to be reassured when their skin condition isn't serious. So a lot of times I know as physicians we feel like we have to heal or do something, but sometimes that something is just reassuring them that their skin condition isn't serious and it's not something that they need to worry about. And just going over good skincare can be some of the best medicine that we can do for our patients. There was one case that I saw in the mission field, and you can see this woman here. I do find that this condition is more common when the parents are of very different skin coloration. So used to be called pigmentary mosaicism. Now we refer to it as segmental pigmentation disorder. And you can see here in this picture that this woman who did have a very dark skinned parent and a lighter skinned parent has, again, this segmental pigmentation disorder. And it's very classic, as you can see here, to be very sharply demarcated in the center. It can be unilateral, can be bilateral, but unilateral is most common with hypo or hyperpigmented patches. It's usually most predominant on the torso. And again, that sharp midline delineation is really important. So these segmental pigmentation disorders, we used to call it pigmentary mosaicism. They can be associated with neurologic, ocular, and cardiac manifestations. And there was a lot of nosologic confusion about these conditions. And instead of calling them pigmentary mosaicism, we are now referring to them as segmental pigmentation disorders. And the important thing is they don't have any systemic manifestations. So you can reassure families when we see this that we don't need to worry about the neurologic, the ocular, and the cardiac manifestations because they don't go along with them. We don't know why people get these conditions. There's some thought that it might be neural or hormonal factors that affect the pigment cells as they migrate. Maybe there's post-zygotic mutation, cellular chimerism can be another possible mechanism. We're not quite sure, but it really does make a beautiful pattern. And with mosaicism, we know that most of the time we get our genes from our parents, both parents, and they kind of mix equally and spread throughout each of our cells equally and giving us an equal pigmentation. But we do know that sometimes maybe more of mom's genes who had lighter skin and dad's genes who had darker skin, they don't mix quite as well, and we get a cellular variant that then proliferates and goes along those lines of Blaschko's as it migrates and takes with it those lighter skin cells, and we get those areas of hypopigmentation. Or if they take the darker skin cells, we get those areas of hyperpigmentation. And then depending, because again, we know that there's somatic mutations, but then we can also have gonadal mutations, and there can be a lot of shame, not just in the US, but especially there. And this woman really struggled with being different. And again, our skin's a canvas and we're all a unique and wonderful work of art. And it was so nice to be able to remind her that she was made a masterpiece. Those opportunities to explain to our patients and educate are key, but they can also help with their social and emotional issues that we know are very common with skin conditions. Again, segmental pigmentation disorders, important to remember, no systemic manifestations, and we can reassure our patients that they are normal and natural and that they don't need to worry. There are no shortage of lessons to be learned, and one is that there's always another way to do something. So warts are hard to treat. They're not just hard to treat here in the US, they're hard to treat abroad. So verruca vulgaris, common warts, as we know, they are viral and viruses can be very difficult to treat. There are a lot of ways that we treat here in the US. Most of them are destructive, and destructive methods can lead to more side effects. So I'm not a big fan of the destructive methods just because I take care of kids, and kids do not like destructive methods because that just means pain to them. So we know cryotherapy is the #1 treatment for warts. We can also use acids and then blistering agents, and sometimes those can be used together in triple therapy. I do want to caution people about using triple therapy. It does lead to a lot of ring warts. It's the only time I've ever seen ring warts is when we've used, salicylic acid and then froze the wart. My favorite for topical immunotherapy is DCPC, dichlorophenylcyclopropanone, and that is a sensitizer. So how these therapies work, there's different ways in the literature. Sometimes people like to sensitize with the chemical. You can sensitize in the literature. A lot of people sensitize on the inner arm. I prefer to actually sensitize on the hip because if you do get a bullous or blistering reaction and it hyperpigments, that can be covered. But I also learned in my 20 plus years of clinical experience in treating warts, which are again really common in kids in the US too, is that if you sensitize right on the warts, it kind of boosts that initial sensitization period, and it really helps to reduce the wart initially. So what we're doing, instead of burning or freezing or scraping or all the things that we do to treat warts that are destructive, where we're just basically destroying the cells that the virus lives in, well, unfortunately, we haven't treated the virus. And the virus likes to come back. And sometimes if you just knock down its house, it still comes back and regrows. And again, that's a big issue with the destructive methods. Not only do they have the risk of the pigmentation changes and scarring and the pain, but they also have a lot of recurrence. So I've noticed that with using these immunotherapies, what it does is it calls up the body's immune system to come to the area. And then what happens is the immune system starts to recognize the virus itself and fights it. And then I've noticed that not only does it help reduce the wart burden and a lot of time resolve the recalcitrant warts that have been around for a long time, but it's not painful. And it also, in my professional opinion, it leads to less recurrence of warts. So again, a great way to treat warts in children. But we did not have that on the mission field. So what they use there, it's a traditional Chinese medicine technique. It's called Moxibustion, and you can see here, there's some photos of that. We're not quite sure how it works, but they take a traditional herbal medicine and they apply it directly to the wart. It can be painted on, or they do have these cones, these Moxi cones, that they can put on top. And the thought is that the mechanism of action is either by direct tissue damage, maybe an immune response or wound healing that happens after the tissue damage. And you can do it directly or indirectly. You do have to be very careful of cutaneous burns. It is a destructive method, if you will. So it is painful. And these kids, I will tell you, on the mission field did not love it. But it was nice to learn about it. And they felt there that it was very helpful in reducing the wart burden in the children that they see. And then also thinking outside the box. I think it's important to think outside the box, not just in our own practices, but when you're on the mission field in resource poor areas, you really have to think outside the box. And it stretches what you know, and you do have to kind of check your expectations at the door when you're on the mission field, and you're not always going to have the resources that you have here. So what was really great about the group in Nicaragua, one of the dermatologists had been there before. They had issues getting sunscreen, and we know sunscreen is really important even for people with skin of color, and they were not able to get it. And also, when you're traveling, you don't want to take a bunch of sunscreen with you. It's heavy, it's hard to get through customs, so they actually made their own sunscreen there. And again, it's hard to say what the SPF was, but they used almond oil, white beeswax, and then zinc oxide powder, and they heated that in big vats, and then they distilled that down and put it into small plastic bottles. And you can see here the pictures of them making the sunscreen. So again, so fun to think outside the box, and being on the mission field really forces you to do so. So those are some of the lessons that I learned in Nicaragua. Then headed to Guatemala. That was actually a trip through my church. There was actually no medical component that was going along with the trip, but this was just a good reminder to me, and hopefully for you, that your skills and your gifts, they travel with you wherever you go. So no matter where you're at, if you're in your clinic, of course, you're going to be sharing your gifts and skills. But we know that we share our gifts and skills with our families and people in our, around us, because if you have a question for your skin, you can always ask it very easily. But do remember that, just to keep your eyes and your heart and your ears open to how you can help, not just on the mission field, but in our communities here. And sometimes you're just in the right place at the right time. And I certainly was. So one day, and I wish I spoke Spanish, but I don't. But this sweet, sweet lady came up to me. She didn't know I was a dermatologist. But we had connected the day before, and she just wanted to tell me all about the skin rash she had. And she had this diffuse dermatitis all over. And so I was, able to go do a home visit, which sometimes go into somebody's house to try to figure out what it was. It looked like it was very much a contact allergy, but I wasn't sure to what. And then I realized that at her age, to contribute to the family, she was doing the wash for all of her family. And she was doing that with the washboard and using the soap. And in Nicaragua and in Guatemala and Latin America, they tend to have highly fragrant soaps just because it's hot, people are sweaty, and she had a fragrance contact allergy. Now, I will tell you, I tried to go into town that evening and find some non-fragrant soap. We had a very hard time doing so. I would say 99% of things are fragranced, as they are in the United States. I have allergic contact dermatitis to fragrance myself. And luckily, again, we have resources in the US, but even that being the case, it's hard to find fragrance-free things. So anyway, we were able to get her some soap, and we were also able to get her some topical steroids, and I was able to treat her there. And then, lo and behold, because I was there treating his grandma, the younger grandchild came up to me, and he had a nickel contact allergy to his belt buckle here. So we were able to tell him that maybe, even though his belt buckle was really awesome, that maybe he shouldn't be wearing it, and that he could use some of his grandma's topical steroids, and just reminded him that it would come back if he re-exposed himself. Allergic contact dermatitis, it's a type 4 delayed hypersensitivity reaction. So poison ivy is the most common allergic contact dermatitis. We do know that, it takes 48 to 72 hours to develop the cutaneous findings after the exposure to the allergen. And that's why they can be so hard to diagnose, is because a lot of people don't have that temporal correlation of the exposure to the allergen. And that's why with people with atopic dermatitis, they already have a leaky barrier, especially kids, and they're being exposed to so many contact allergens through their leaky barrier that induces this type 4 delayed hypersensitivity over time. And again, because it's not temporally related to what's being applied, the skincare product, sometimes it's hard to figure that out. We know common contact allergens are fragrance, the formaldehyde and formaldehyde releasing products, topical medicines, especially Neosporin, and then certainly metals. And then if you get so much exposure over time, you can get a systematized allergic contact dermatitis, and you can get cross-reactivity with certain foods, and that can lead to an id reaction where you get itchy papules distant from where the actual contact is. And I actually get that from fragrance exposure. So again, I know that well. So that id reaction where you get the papules, they can be around your hairline, on the elbows and on the knees, and they're very itchy, and it's not from direct contact, it's from the systematized allergic contact dermatitis. And Dr. Kata, kind of our resident expert here in Houston, she's got a great website and free patient handout. So definitely, if you have a patient with suspected allergic contact dermatitis, go to her website, print those out, or give them to your patients the link so that they can have access to that great information. And then another great way to get information as a learner is to listen to one of our T4 talks that was one of our originals, Conquering Childhood Contact Dermatitis. I did that with Dr. Nena Gim, who's in the Dallas-Fort Worth area. She's a great pediatric dermatologist and teacher. So we have that in the files. So definitely, if you're trying to brush up on contact dermatitis, she talks about common childhood contact dermatitis and also systematized contact dermatitis. And there's a lot of board pearls scattered throughout that talk. So definitely jump on and listen to that one again if it's been a while. Thank you for going to the mission field with me in Nicaragua and Guatemala. And I can't wait to be back and share a little bit about the mission field in Kenya.